my disclosure statement is that I have nothing to disclose. So our objectives for this evening are to review the clinical presentation and management and complications of several serious pediatric diseases that should be readily recognized by the practitioner caring for children. And I chose these because of their rarity, but also because they are diseases that you will see in pediatrics. So not being so rare that you're not going to see them, but not your everyday clinical view. So what hotspots do we visit today? Kawasaki's disease, very common disease in children, and if you're practicing in pediatrics and you're at a community hospital, you probably see one or two of these a year. Stevens-Johnson syndrome, you probably will see one of these in your career. Measles and rubiola, only because now we're in the midst of an outbreak, and for this year we have over 200 cases of measles in this country. Group A strep toxic shock syndrome, because a lot of times we have questions about this disease, a very common disease, scarlet fever and group A strep with its endotoxin. And then Henlock-Schönlein purpura is our last one that we're going to talk to. So we're going to start with our case first. So I've got a 20-month-old infant with a 5-day history of fever and irritability, and she was seen in the emergency room 3 days ago. And of course, she was diagnosed with otitis media and given amoxicillin. And then she developed a rash on the amoxicillin that was then stopped because it was thought that it was developed secondary to the antibiotics. She had a temperature of 103, and her mom was using Tylenol and Motrin without much relief of her fever. Her fever was basically very constant and very high, 39 to 40, just did not get any relief with the antipyretics. She seemed more irritable than usual and difficult to console, but she just didn't look toxic. The child was drinking less but with decreased urine output. So a review of the symptoms of fever, irritability, decreased PO intake, decreased urine output. She had a rash, she'd vomited ×1. At this point she had no diarrhea, no shortness of breath, no pain, no sick contacts. Her family history was non-contributory, and her social history really was not either. She had not traveled outside of the United States, and her immunizations were all up to date. Her vital signs basically just showed a fever. It was positive for these cracked lips, an injected conjunctiva. She had normal terminates, but her ETMs were erythematous, and this was thought to be secondary to her fever. Her oral pharynx was erythematous tongue, sort of like a strawberry tongue, and she had white tonsillar exudate. She had bilateral cervical lymphadenopathy that were 1.5 centimeters on the right and 0.5 centimeters on the left. Her lungs were clear with no wheezing. She was tachycardic with a normal rhythm, and she had 2+ pulses. Her abdomen was soft, non-tender, non-distended, and she had good bowel sounds. I think the most important thing is the description of her rash. It was a red, blanching, slightly raised, polymorphous rash over her extremities. So it really looked like different things over her entire body. Her neurologic exam was irritable. She was difficult to console, but again, did not look toxic. Her genitalia were normal female with some desquamation of the genital area, and her extremities were normal, except that she had puffy hands and some puffy feet. So her differential diagnosis at this point included infectious diseases, as you can see here. And indeed, of the two etiologies, we're going to talk about infectious and autoimmune. They make up about 2/3 of the diseases that we consider when we see Kawasaki's disease, which is indeed what this child had. Very difficult to tell from group A beta hemolytic strep. That's always a question. Measles also. Other diseases, bacterial diseases that would have a similar rash would be severe staph infections with a toxin relief, and then virals, adenovirus, enterovirus, ABV, and roseola. And as I said, the immunologic, allergic, autoimmune, JRA, atypical, acute rheumatic fever, and a hypersensitivity reaction, something like a serum sickness or a serum sickness-like illness would be one, and Stevens-Johnson syndrome. There are some differences, and hopefully we'll talk about them during our conversation together. As you can see, these are examples. This is not the patient of which I'm referring, but examples of indeed the cracked lip on this patient. uh, the desquamating, or I'm sorry, the desquamation down in the perineal area, as you can see over her vulva. It's sort of red and uh, uh, desquamating, and this sort of erythematous, non-specific, very common, looks like the normal viral exanthem that you might see. And notice that she has conjunctival injection, and this was bilateral. It was without any exudate, which was noted. And again, you notice that the rash does cover her hands, and her fingers are puffy, and that's better seen on this picture of her feet. And again, this is a picture of the buttocks of another patient that shows the desquamation that can occur, including the perineal area, also on the hands and feet. So Kawasaki's disease has multiple symptoms that are associated with it. We can't cover all, but some of the more common ones in children are rhinorrhea, a cough, and a pulmonary infiltrate. They may have diarrhea, and I see that very commonly, especially in the younger kids, vomiting, abdominal pain. And then if you do an ultrasound, high drops of the gallbladder and jaundice can be seen. They are extremely irritable, as if they're in pain, but you can't really find the pain anywhere. They can, if you would tap them, would have an aseptic meningitis, may have a facial palsy and some hearing loss. And again, more serious cases can have myositis, arthralgias, and arthritis. The laboratory findings on these kids are really not specific when it comes to their white counts. They will have and can have a increased white count, which looks like a left shift. Oftentimes, because of the urine, UA will have white cells in it, but we will be nitrite negative, but leukocyte esterase positive. So you might consider that they, because of the high fever, because of them looking ill and being dry, that they might have a urinary tract infection. Again, they do develop an anemia. And the platelets, and we often hear that the platelet count is increased in children with Kawasaki's disease, but that really is a late onset finding with them. As I said, their UA may, as with this child, shows specific gravity of 1030 and her ketones are 2+. Unfortunately, they did not comment on, with this case, on her white cells, but a very common finding. Her electrolytes were noted to be normal, and again, she had a full workup done. So with Kawasaki's disease, as I said, there are these findings that are very common. The increased white counts of the leukocytosis with the left shift, the mild anemia that this patient had, the thrombocytopenia initially, and then a thrombocytosis. Of course, there are elevated acute phase reactants, both the SED rate and the CRP. An interesting finding, if you do a full set of Chem 14, would be hypoalbuminemia. And elevated liver function studies and the sterile pyuria. These are all very common, and I can say that out of most of the kids that I've seen over the last year or so, most of these findings have been there. We also talked, and let's go back and flip back a slide. I'm sorry, I can't get it to go back, so let's try this. Okay, it's taken me way back, so we'll go forward again. Okay, the thrombocytosis and the elevated CRP can be late. So nobody really knows what the cause of. It affects all races. It's seen throughout the world. Asia is where, and actually Japan is where it describes. And for some reason, there seems to be a predilection to children of Asian descent. 80% of the children are less than 5 years of age. And really the range is around that toddler, the 18-month to the 3 years of age is where most of the kids fall in. Very rarely, if all, seen at teenagers and adults. Boys tend to have a little more disease than girls, and about 3,000 children are hospitalized annually in the United States. So you are going to see this. The mortality rate is low, and that's especially if we catch this early. And the mortality is usually caused by the cardiac complications, and in all cases. And cardiac complications can be seen in up to 20 to 25% of children. So, as I said, our case number 1 was diagnosed with Kawasaki's disease. which is a generalized vasculitis of unknown cause. The patient received IVIG. She was started on aspirin. She got a cardiac echo that was normal, and she was improved within 24 hours. Was watched within 12 hours. Was watched for 24 hours in the hospital and did not require any more treatment and was not thought to have any more complications. So again, with children, their criteria for diagnosing this disease. Fever is the hallmark, and fever for a minimum of 5 days to make this diagnosis. This bilateral non-exudative conjunctivitis, which can be differentiated for something like like Stevens-Johnson syndrome, or a viral or a bacterial cause of it. They have very cracked, fissured lips, more so than what you would expect for their degree of dehydration. It doesn't improve when they're rehydrated. The injected pharynx and the strawberry tongue, it would make you think of strep as an etiology with this kid. Erythema and palms of the soles and edema of the hands and feet. And indeed, very few things will show this. They also have a concomitant hypoalbuminemia. And then this polymorphous exanthem that for some children is very mild and for others much more involved. And then they have this acute non-suppurative cervical adenopathy, pretty large adenodes, lymph nodes, and at least one node is greater than 1.5 centimeters. So you've got to have the fever and several of these findings. So with Kawasaki's, there are 3 basic phases of the disease: the acute febrile phase, the subacute phase, and then the convalescent phase. And the convalescent phase is that lasts the longest and where we see the issues of cardiac disease. The acute febrile phase generally lasts from 1 to 2 weeks, during which you see the typical signs of fever, rash, the mucous membrane inflammation, edema, and lymphadenopathy. The subacute phase begins as initial clinical signs resolve and desquamation of the skin, thrombocytosis and coronary aneurysms develop, and the subacute phase generally occurs for 2 to 4 weeks after the onset of the fever. And during the convalescent phase, all clinical signs and laboratory evidence for inflammation, the elevated SED rate, and CRP resolve, usually 6 to 8 weeks after the onset of illness. So it can be an illness that resolves on itself. Luckily in this country we are aware of it, and we tend to evaluate those kids very soon after. There's no specific test. Again, the fever for 5 days and the clinical findings are how one makes the diagnosis of this disease. We don't know the cause, and the morbidity and mortality from coronary artery thrombosis and diseases and coronary artery aneurysms up to 20 to 25% of children. There are EKG changes that can be associated with arrhythmias, and the EKG changes are very protean. They're chest x-rays, they can have cardiomegaly, and again, these echo findings. So the treatment of Kawasaki's disease is IVIG, and 70 to 90% of children defervesce after the first dose of IVIG and are ready to go home. However, a small number require 2 and 3 doses of the medication to resolve. So you do treat them with up to 3 doses with the IVIG. After that, treatment is much more complicated and specialized. In a case report, Remicade, an anti-inflammatory, has been used in these children. Aspirin, the use of aspirin is pretty standard in children with Kawasaki's disease. Again, high-dose aspirin is theoretically used to suppress inflammation. So use high-dose aspirin until the fever resolves, which would be an indication of inflammation. And then after that, it's to inhibit platelet aggregation, because remember, in the later phases, the platelet count can go over 1 million. Okay. Again, so the management, IVIG, high-dose aspirin, and then later low-dose aspirin, cardiac echoes, and serial cardiac echoes if you see anything with these hearts, and then clinical follow-up for these children. Just remember that not all children have the disease. The children less than 1 may have an atypical complete presentation, and you just have to have a high index of suspicion of these kids and follow them very closely. So case number 2 is an 8-year-old who developed an upper respiratory symptoms with a fever, cough, and tachypnea and malaise several days before a purulent conjunctivitis and erosive mucositis. She also had a blistering skin rash. The cutaneous lesions were relatively limited, and the oral lesions and conjunctiva began to improve 3 to 4 days after she presented. She had a rapid test for mycoplasma that was positive. And interestingly, her mother had a history of pneumonia treated with oral antibiotics several weeks earlier. And her sister developed a cough and a mild but similar rash several days after the patient was hospitalized. So this patient presented and was diagnosed with Stevens-Johnson syndrome. And she had a typical presentation in that she had a cough that was productive of thick, purulent sputum, headache, malaise, arthralgias, fever, epistaxis, the conjunctivitis, corneal ulcerations, and this erosive vulvovaginitis. All of those go along with it. It's a cell-mediated hypersensitivity response. The clinical presentation is multi-organ, multi-system, with the eye, the kidney, the liver, skin, and the mucosa being the most involved. Precipitating factors are really sort of diffuse in these kids. Drugs, antibiotics, and we all know as clinicians, Bactrim is the one that's implicated very commonly. Anticonvulsants, phenobarbital and dilantin, very common in children. Infective agents, mycoplasma, and herpes simplex, the most common. And in adults, interestingly, I found out when I was researching this, malignancies may be the finding. And we'll talk a little bit about the management of this later on. Again, the adults and the elderly, the drugs and malignancies are the most common. And then children, they're related more due to infections. There seems to be a time of year for this, the spring and winter. There, again, is a male to female ratio of 2 to 1, Caucasian predominance, and the mortality rate is 3 to 15% in those kids who are more severely affected with this disease. And again, the mortality greater in the 2nd and 4th decade. So as I said, this typically can begin with a nonspecific upper respiratory tract infection. The sort of timing of this is from 1 to 14 days with the sore throat, the chills, the headache, the vomiting, diarrhea, malaise may be present. So these kids really are nonspecific early on. And when they develop the rash, you begin to notice that they have this. So then the mucocutaneous lesions develop abruptly, and they can last for 2 to 4 weeks. And this is really where the morbidity and the mortality occurs, depending on the extent of the involvement, for instance, of their skin. And many of these children are treated in burn units because of the fact that they lose so much cover their skin protection as an organ, and so they are at risk for infections and fluid issues. So this rash can last for 2 to 4 weeks. It's typically not pruritic, and it may lead to mucosal scarring and loss of function of the involved organ system. Now, this basically shows the bullae that these children will develop. And then once these bullae denude, you get the erosion, and this can occur both on the mucosal surface and on the general skin surface of the child. This is a child who you see has, you can imagine his lips, he's got pretty significant mucosal findings. And again, you can see he's got some desquamation on his skin. This is a child who has a more confluent, and if you can imagine, and I'm sorry I don't have a pointer, you can see target sort of lesions there that are, pathognomonic of the rash associated with Stevens-Johnson syndrome. So the complications, the more serious, obviously, because it does affect the mucosa, thank you. They can have esophageal involvement. That can go on to develop esophageal strictures, the tracheobronchial mucosa shedding, and then they can get respiratory failure, basically an ARDS kind of picture. And then with the eyes, corneal ulcerations, anterior uveitis, and keratitis, panophthalmitis with these kids, which can go on to develop blindness. They can get vaginal stenosis depending on how serious, again, the involvement is in penile scarring associated with that. This is an example. Now, if you remember in the child who had Kawasaki's, she had a non-purulent conjunctivitis. Wasn't as red and didn't look like this. And looking at this child, you might suspect Kawasaki's with her. She's got the cracked lips. But again, does she meet the other criteria? And this conjunctivitis is purulent with the edema of the lids and the conjunctival hemorrhage. So much more of a vascular involvement with this. And she also had the vesicles and the intranasal and the lip erosions, which are different from what you would see in a child with Kawasaki's disease. And again, if the offending agent is not found, these children may go on and have reoccurrence of this. As I've talked about, many drugs are involved. We tend to think about the sulfa drugs and again, Dilantin as a part of this, but as you can see, there's a long list of drugs. And then viruses, herpes simplex, what we note more often, but and mycoplasma, those two we commonly hear about, but then a wide variety of viruses. And then if you look at some of these kids, they do have the tumor necrosis factor alpha, which you see in sort of hyperimmune diseases. And then these other factors that are there. However, none of these are pathognomonic for this disease process. Their lab findings may reveal a normal white count with a non-specific leukocytosis. And if they do have a severely elevated white count, even though they have all this inflammation going on intrinsically with this disease, you need to think about a bacterial infection. So the skin lesions are treated as if they're thermal burns, as I've said, and with these kids going into the burn unit. And these kids really, or patients really range from just sort of a mild erythema multiforme up to a TENS, which is the erythema necrosis that you get, which looks like the burn. The airway, again, are things that you need to be concerned about because of the mucosal involvement in the sloughing. Their fluid status because of their loss of skin and then therefore loss of fluids and the electrolyte imbalance that can occur with that. And then pain control, as I said, just as you would do in a burn patient. And so the treatment is basically hopefully finding the offending etiology of it, and then symptomatic coverage for them. Again, oral lesions you can treat just sort of as need be, and the areas of denuded skin, again, treat as if they are burns. The use of steroids are really controversial in this disease. High dose may be helpful early on in the disease process, but they seem to increase morbidity and mortality. I think much of that is related to their immunosuppressive response. So really not the drug of choice or a panacea for the treatments of Stevens-Johnson syndrome, even though it is a hyperimmune status. So this is a disease that we see commonly. This kid is showing you his or her nice strawberry tongue with what is perioral pallor that can occur. And in this child, the throat culture was positive for group A beta hemolytic streptococcus. And this is a disease that causes scarlet fever, strep throat, and then also it can cause a toxic shock-like syndrome, very similar to that which is seen with staph, but different cause at this point by strep disease. And in this patient, as you can see, this sort of fine, if you were able to feel this sort of fine sandpaper type rash with in the creases a clustering of the redness in the rash, which would show Pastia's line. The very good thing about group A strep that it's very easily treated. And so picking the right antibiotic, these kids, if you treat them appropriately, are usually non-infectious within 24 hours. And again, like Kawasaki's, we've got the strawberry tongue, we've got this rash, we've got the age distribution, the fever, and you can also get peeling in the same distributions as you would see with Kawasaki's disease. So you can see differentiating these is not so simple a finding. Okay. Again, this is the sort of erythematous rash that you can see on this child's foot. And this, if I can bring down the, hold on just a minute, if you can be patient with me as I go back on a slide here. Let's see. Back a little bit too far. Back here. Sorry about that. Technology and me sometimes have a little bit of a conflict. And this is my first time using this system, so gotta just get used to it. Okay, I'm going to try to point out the Pastia's lines if I can use. I don't think mine is getting the arrow to work. The Pastia's lines, if you look at the crease of the elbow, you can see that dark redness, and those are called Pastia's lines. Great. Thank you very much for that magic person who did that. What is, I think, most important about group A strep are the clinical complications of it. And again, that is why we treat this disease. It is usually a self-limiting disease process that would be can be over in 10 days. It's just sort of self-limited, treat yourself. And really, in uncomplicated group A strep, doesn't cause any problems. So we'll talk a little bit, we've talked about the clinical manifestations. The management of it is actually using the correct antibiotic. And I think it's to remember that almost universally, group A strep is sensitive to penicillin. Penicillins, clindamycin might be a good choice. However, there has been a report of pretty significant macrolide resistance. So one of the major complications, and the reason that we actually treat these children, and what was historically pre-antibiotic age, the reason for mortality is acute rheumatic fever. And again, just as a reminder to you, I put this in here to help me remember, because it's not something that you see often, but you need to be vigilant about it, especially as we have children who are coming from third world countries. And if you and subcutaneous nodules are there. And then the minor criteria, the fever, arthralgia, elevated acute phase reactants, and then in prolonged PR interval on the EKG. And the diagnosis is made with one major and two minor, or two major and one minor finding. Again, another serious complication of this disease, and one that you need to be aware of, is a staph streptococcal toxic shock syndrome. We hear a lot about staph toxic shock syndrome, but again, strep can also look at this and can be a really serious finding. So if you see a child who comes in who looks like, or a patient who comes in and looks like they have strep, but they have a low blood pressure or developing shocky, this is something to think about. Again, antibiotics are what you would need to use. You also might consider looking for the site of this, if it could be a skin infection with these kids, because we have not talked about the fact that it can cause a bullous impetigo or impetiginous or erysipelas type infection. Also can cause soft tissue necrosis and that necrotizing fasciitis that we are afraid of. Okay. Our next case, uh-huh, yes. Hello? 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 Okay, can you tell me where? Okay, so again, sorry about that, guys. A complication, and one of the major complications, and the reason that we end up treating and are so vigilant and do all these throat cultures and all these things to find group A strep is because of this major complication, which is acute rheumatic fever. And while it's not frequent, it's something that we do need to stay vigilant about. In my practice, I have two children who are on chronic penicillin therapy because of their acute rheumatic fever. And if you treat children who are coming in from third world countries, children who live in crowded conditions, this again would be a concern. So they're the major criteria, and I always put this slide in my talks about group A strep just to remind me as to what they are. And the minor criteria, as you can see, are here. And just to remember that you need a combination of either two major with proof, serologic, throat culture, ASO titer proof of a strep infection, or one major and two minor. Okay. Another complication of group A strep, and again, most often seen not with the pharyngitis and respiratory presentation of this disease, is streptococcal toxic shock syndrome. And if you remember necrotizing fasciitis several years ago in the news, this is a disease that can cause this. And so again, shock by definition is hypotension. So if you see a child who has this sort of erythematous red, bullous, fast moving infection with a history of previous trauma, think group A streptococcal disease, and treat appropriately for that. So my next patient is a 6-year-old, comes to my office complaining of migratory pain and swelling of the joints. 3 days prior, he experienced pain and swelling of his right hand and knee. And the following day, the pain and swelling had spread to his right ankle. He complains now only of right ankle and lower back pain. So there's sort of migratory pain everywhere. The joints are warm, but there's no erythema that's noted. And he's been healthy with no history of fever, runny nose, cough, vomiting, sore throat, or diarrhea. He was bitten by a tick 4 months ago, and there was no family history of arthritis. His physical examination, he's a friendly boy and no obvious distress, and his vital signs, including blood pressure,